Welcome to our third session of this 5-session series on suicide prevention in primary care. Today's session is Preventing Clinician Suicide, Overcoming Barriers and Reducing Stigma to Care for the Healers. A very important topic that I'm very interested in hearing today. I am Cindy McDonald. I'm the Behavioral Health Program Manager at Missouri Primary Care Association, and we are honored to be able to present this in conjunction with the Association of Clinicians for the Underserved. And with that, I'm going to turn it over to Rick from ACU for further introductions.
Thank you, Cindy, and hello, everyone. And thank you so much for joining us for today's presentation. We're so glad to be able to collaborate with Missouri on this ongoing series. My name is Rick Brown, and I'm the Associate Director of Communications and Membership with ACU. I'll be your host for today's webinar. For those of you who are new to ACU, we are a transdisciplinary membership network uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help achieve health equity for all. We do that by supporting the healthcare workforce, caring for America's underserved communities with trainings, technical assistance, advocacy, and much more. And we invite you to learn more about us, including our currently active call for abstracts for our 2024 conference at clinicians.org. If you're interested also in more resources on suicide prevention for patients and clinicians alike, we also encourage you to visit our Suicide Safer Care page. There you can find a variety of fact sheets, toolkits, archived webinars, and more. And we also have a dedicated page of resources for preventing suicide in clinicians to support today's training as well, including a brief on organizational approaches to support staff well-being, as well as advocacy and awareness raising materials. You can scan the QR code to visit or simply go to bit.ly/suicidesafer. Before we begin, I also just wanted to go over a few quick housekeeping items. We will be recording this session and we'll send you the recording and slides within a week of the webinar. We also encourage you to ask questions during the chat as you think of them as well. Dr. Little is great at taking these on the fly. Also, at the conclusion of today's training, please complete our brief evaluation. It's very useful to help us continue to improve the quality of our trainings. Lastly, I am honored to introduce today's speaker. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. She is a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large FQHC network in New York. And with that, I'll turn it over to Dr. Little to kick us off.
Well, thank you. I'm really glad to be here today and super excited to have this conversation. And it's interesting, I'm actually on the road now and doing some suicide safer care trainings for some healthcare organizations. And I've just asked some folks as I've been in the organization, and unfortunately, both of the organizations that I visited, which are both hospital and also large outpatient primary care, actually talked about the multiple provider suicides that they've had over the past couple of years. And so what we're really hoping to do today is to have some conversations around how do we actually get in front and prevent suicides in our teams and in our providers. And so really wanting to have some discussions and have some thoughts, because unfortunately, I think all of us really need to think about that as part of our planning, how we're really going to get in front of what is a crisis. And so I really think, just to reiterate, it's so important, when I talk to individuals who are clinicians and providers and they're at risk for suicide, and I ask them about their reasons for living. One of the things that we do when we're doing safety planning for individuals is we ask them about their reasons for living. And so many of them say, my organization, particularly in the health centers, like my patients, it is actually one of their reasons for living. But unfortunately, what happens is they often will really sacrifice sort of their own well-being and not really get the care or take the time to get the care that they need. Or unfortunately, many of us work in areas where there aren't resources. And so oftentimes there's limited care. So really wanting to just put that out ahead. because one of the things we know is that the number of suicides is continuing to increase. It's continuing to be one of the top leading causes of death. And, you know, one of the things that we've learned, and we talk about this, is that many of the people who die by suicide don't have a mental illness at the time of death. It's really just the overwhelming stress and pressure, oftentimes of residency or training. It's financial problems, relationship problems that really actually culminate to really put someone at risk. And oftentimes we think about individuals who are very sad, and we look for people who maybe are very sad or have, you know, some real symptoms of depression, and that we forget that anxiety is a huge risk factor for suicide also. And oftentimes we don't think about somebody who's very anxious being at risk for suicide. And these trainings are part of a larger project where we've gone now to train over 4,000 primary care providers in their teams on how to do suicide safer care with patients. And I always talk about the fact that in all of those states, I never went to a residency program where a resident didn't come up to me and tell me about someone that they lost in medical school or residency to suicide, not one single time. And so I think it's really important to make sure that we're doing this. So I just want to double check, is there a problem with the slides? Okay. So thinking about suicide and healthcare workers, you know, really thinking about the emotionally difficult situations, and if people don't have an outlet, also oftentimes really exposure to just suffering and people who are losing their lives. Also, you know, this is something that we don't think about, but is really important, is that we do have individuals who work with us who have access to lethal means, medications in particular. And so I remember working in the FQHC, we actually had a free clinic, and, you know, we did not take medication samples outside of the free clinic, but we actually had like a storage area for supplies for the free clinic. And I had someone from the team who actually overdosed and tried to die by suicide in the practice one morning before the free clinic opened. And so really do sort of thinking about the fact that people do have access to lethal means, and it is a consideration. Also thinking about burnout, and one of the things about burnout, and burnout is a term that we use a lot, and we actually forget that it really does sort of have some very specific criteria. But one of the things about burnout is that it leaves people feeling very overwhelmed, and it leaves them feeling very helpless and hopeless. And one of the things that really creates someone or really increases someone's risk for suicide is a feeling of hopelessness. And so people who have hope often don't choose suicide. And so when I'm feeling hopeless at home and I'm feeling hopeless at work, then it really exacerbates someone's risk for suicide. And so oftentimes I know what I do, and I think this is a good sort of organizational managerial, is that when I hear someone say, I just feel hopeless, or this is hopeless, I actually oftentimes will reframe and say, you know, it's really hard to be able to see some of our successes, you know, when we're so busy and caring for so many patients with such high acuity. And then I'll maybe recount something that I remember as being a success and encourage that person to do the same. And so the ability then to not let someone stay sort of in that hopeless place, and almost in a way teach sort of reframing. And a lot of times that's just a really important piece and can be really helpful for people because that is a big contributor. And so really thinking about suicide in terms of physicians, you know, we're losing almost a physician a day to suicide. And so when we think about the methods, oftentimes medications are methods for individuals who are at risk, for providers who are at risk. That actually is one of the top causes, and much higher than military and law enforcement. So we hear a lot about veterans, we hear a lot, but actually people in healthcare have some very high numbers, and I think don't actually get the attention or the press that oftentimes others get. So when we think about suicide, particularly among women providers, that is actually generally higher. I also don't like to forget about our nursing and some of the other folks on the team. We actually didn't know how high the rates were in nurses until someone looked at it a couple of years ago, and many of us have nurse practitioners that make up a large part of our provider workforce. They are actually at considerably higher risk. And so really making sure that we're paying attention. And when we think about the percentage of suicides, it's actually almost 12% of the suicides are individuals that work in healthcare. And so that's a pretty high number to really pay attention to. So when we think about the culture that we're creating in our organizations, that's really where the key to prevention comes in. And so oftentimes when we think about residency and training programs, that sort of culture of you have to be tough and it's going to be a lot and it's going to be all consuming, that's where people really start to struggle. And I think creating an opportunity for people to get a little bit of a break, for people to be able to voice that they're struggling. And, you know, oftentimes we have this misconception, you know, I was actually with some neighbors the other day, and there was someone that was feeling sad, and you know, I was talking about supporting them in the neighborhood, and people overwhelmingly sort of said, well, they just sort of have to toughen up, like that still idea of, well, you know, you just got to pull yourself up by the bootstraps. And I think that really still, that overwhelming sort of prevalence of thinking actually is still in a lot of our training programs. You know, you just have to toughen up. And I think that actually really limits people's ability to feel comfortable. And I often talk about a training that I did in a residency program, and I actually gave out a questionnaire around suicide, let it be anonymous. And I was shocked at how many people in the room actually, you know, scored that they had thought about suicide fairly recently. And so I think that's one of the other pieces to really start to think about. And when we think about a fifth of our residents actually experiencing depression, and that most of them don't get treatment. And I think that's actually a huge piece. And so when we think about prevention, one of the things that I would strongly encourage is from day one, when you're onboarding, you know, if you have like a teaching health center or you have a residency program, from day one, really talk to residents or trainees about behavioral health, about where to get support, what benefits are available to them, how can they access them. Let them know that it's not going to impact their ability to be successful in training or in the program or even to complete the program. Finances are often a big concern for them. How much does it cost? Are there places where they can get treatment or be able to call and talk to someone? So what's really helpful is the 988 line is actually out there and available. And one of the things we can do is just let people know, hey, if you're feeling overwhelmed and you start to think about suicide, you know, you can call 988, you can step out, you can call 988. It's 24 hours a day. It's something that you might find helpful. Like, it's okay to do that. We're going to give you the information so that you have it. We're going to post it on the bulletin board so that you don't forget it's there. And I think having that conversation right from the beginning is really helpful. And it really then creates an opportunity to talk, and also really letting people know what to do if somebody does make a suicidal statement or somebody does actually start to show some symptoms. And so really keeping an eye on individuals. And so one of the things we know is that we haven't actually created systems where providers often feel comfortable getting care or treatment. And one of the things that comes up oftentimes is in a lot of community health centers in particular, because they do, exist in under-resourced communities, is oftentimes we have some processes in place for people to get care in our own organization. And oftentimes we, have individuals on the team that get care in the organization, but oftentimes, particularly providers, some of the primary care providers don't feel as comfortable accessing those services. And so having a conversation about how can we address that as a team? Are there other resources we can direct them to? Do we have a relationship with one of the online treatment providers? There are many out there. There's Ascend, or there's LifeStance, or some of the other organizations that provide telehealth services. Can we actually have a relationship or connect them? And is that something that would be covered on their benefits, so that we let individuals know that that's available and here are the resources? And I think now, particularly with the telehealth services, then that really gives people some additional options. But I think you really have to give people that information, give them a handout, let them know that those options are there, because otherwise they're not going to get care. And then you're hopefully going to discourage people, or rather you're going to be able to put some preventative care in place and not let people not have any resources or feel like there's no place for them to turn. One of the things that unfortunately happens is that when someone in the community dies by suicide, everyone becomes more at risk. And so there's been plenty of times where a resident or a provider has died by suicide, and then other providers, healthcare workers, patients, everyone becomes more at risk, and people who are already at risk become more at risk. And so oftentimes when we have a suicide in the community, we don't often think about how that then translates to what we need to do in our own staff. And so if you have providers that are already at risk for suicide, already having suicidal thoughts, and someone dies in the community by suicide, oftentimes that puts them at much, much greater risk. And oftentimes we're maybe even having some discussions about how we can address risk in the community or in our patients. And we forget that that actually puts our team members way more at risk as well. So we really want to think about how we share the information. So if we had a patient die by suicide, then one of the things we want to include is where people can get resources. Here's the 988 number to call if you're thinking about suicide. Here's a summary of where you can get care or treatment. Here's what's available to you in our behavioral health benefits, so that you're actually coupling the information with an organizational sharing of information in the news with information and support. And one of the things that I hear from organizations and from providers a lot is that people don't, or organizations don't think about sharing the information until they have to share it. And so oftentimes the messages is inadequate. It leaves people feeling confused. It might even increase risk. And so I strongly encourage you, as part of a prevention effort, to craft those emails now, so that if you have a patient die by suicide, you have someone in the community die by suicide, or even a provider die by suicide, that you actually have a plan to be able to share information that's going to be supportive to individuals, and also going to be helpful for those who are then going to be more at risk. So I really encourage you to think about it. Oftentimes we talk about organizations doing that hazardous vulnerability assessment. Put provider and patient suicide on that hazardous vulnerability assessment, so that you can start to think about it beforehand. The other thing that I would do in terms of sharing information is oftentimes we have provider meetings, right? Maybe they're quarterly, maybe they're monthly, sort of depending on your organization. And I would actually put this on the agenda for one of those upcoming meetings, and we'll, certainly share the slides, so that you'll be able to say, you know what, I'm not sure if people in the room know this, but one of the things that we know or that we've learned is that suicide is a real problem among healthcare teams, and it's a real problem among primary care providers. And so we really wanted to have a conversation. Here's some information around the number of people affected. Here's what we think might be helpful for people. We'd actually like to really talk about how we could support and prevent someone on our team from dying by suicide. What would that look like? And really asking people so that we're having an open conversation around suicide with all of the providers, that you're hearing from them what would be helpful for them or some information or resources. And you might actually be surprised that someone self-discloses that they've had thoughts of suicide. I would not be surprised about that at all. And that person might even turn out to be a champion and doing some of this work. So really encourage you to do that and to actually put it on an agenda for an upcoming provider or staff meeting. So when we think about suicide and suicide prevention in your providers, it's going to be really important to train your medical directors, your physician leadership. It does take absolutely an organizational approach. This is an organization where we talk about suicide and really think of a systemic approach. How can we reach all of the providers? How can we give them information, right? Is there information that we send out to providers that happens on a regular basis, right? Is there some informational sheet that we can put on a share drive that people have access to? So if they want information, they know where to go to get it. Is it, or can it be part of some kind of yearly HR or people team updates? And one of the things that's really important is oftentimes I've heard from so many medical directors, from medical, chief medical officers, where people actually talked about suicide before they died by suicide, and that people in the health center had actually heard someone make suicidal statements or knew that there was something going on in their life that was causing them stress and might put them at risk. And so it's really important to train medical directors to be able to ask questions so that if someone makes a suicidal statement, that they pull them aside, they sit down and say, many people in our profession think about suicide. And today, you made a suicidal statement to one of our colleagues, and your life is really important to me, and I'm concerned about you. And I'd like to talk to you about your thoughts of suicide because we'd like to support you. That you actually give language for medical directors, for medical leadership, for providers to use so that if someone makes a suicidal statement, they have a response, that people in the organization know what to do and that there's a bit of a process. And what I would really strongly encourage is that in the medical provider meetings, in some of your leadership meetings, that you actually practice what would we say if someone made a suicidal statement. If I pulled one of our medical providers into a room that had made a suicidal statement, what would I say? And I think it's really helpful. When we do the suicide safer care trainings, we talk about storage statements and having 2 or 3 sentences ahead of time that you could say to someone. And I think it is really helpful to do that. And when you think about a primary care provider in particular, maybe saying something for the first time or for the first time actively or openly talking about their thoughts of suicide, that's an incredibly important conversation and could actually determine whether or not they ever talk about suicide to you or in the organization or even at all again, or whether or not they're like, this was helpful and the people in this organization and my team are here to support me. And so I do think it's really helpful to practice and have those conversations, to think about the approaches. And I can tell you again, it's not a matter of if, it's a matter of when this happens. If it hasn't happened in your organization, start thinking now, because again, this is something, suicide and suicidal statements and suicide among providers and team members is something that organizations are grappling with nationally and really trying to think about ways to address. And I know that we often talk about ways that patients fall through the cracks, but I really think it's important to think about the ways that our team members and our primary care providers fall through the cracks as well. And one of the things that came up recently is that there was an employee assistance program that providers and people were referred to. And there was a physician assistant actually who disclosed, thinking about suicide at work, and people talked to him and they actually gave him some time and he was going to contact the employee assistance program. But it came to light that the employee assistance program wasn't actually prepared to care for someone who was thinking about suicide, and that it actually was not as helpful to him. And so that's something to really think about. So does your employee assistance program actually know what to do with someone who's at risk for suicide? Is there something, is that something that you require of them? Do they have training? Would they actually know what to do? And unfortunately, many don't. And in fact, when we talked about with behavioral health providers, many of them are not trained to care for people who are at risk for suicide. And oftentimes, I get the privilege of working with Dr. McKeon, who runs suicide care for the country. And he often says the only training that he got was a class that he taught. And so really making sure that you're not going to lose people through the cracks and that there's something very specific set up for them. And one of the other places that people will often fall through the cracks, particularly, is part of keeping people safe. We used to do something called contracting for safety. We don't do that any longer. We do safety planning. And oftentimes people will say, well, safety plans, particularly for healthcare workers, for providers that have access to lethal means, oftentimes work needs to be involved in safety planning. So, I one time was working with a medical provider and they were at risk for suicide, and we did a safety plan and talked about things that would be helpful for them. And then we started to talk about lethal means, and they were going to use medications. And so, we talked about how to keep them safe at home, and we did some planning, but then we actually needed to sit down with the medical director and we needed to talk to them about how to keep someone safe. And so oftentimes I will ask individuals, if we were going to keep you from dying by suicide today and using medications, what would we have done? And oftentimes it might be, I would need to talk to my medical director, or I would need to talk to my practice administrator, and maybe I don't have keys to the medication closet, or maybe I have to come get a key, right? Or that there's some difference. And we also want to do it in a way that's confidential and respectful for someone. And so many, many times, particularly providers that are at risk for suicide, it's going to mean that leadership at the center or at the practice are involved in a safety plan. And so really thinking about what would we do if we had a provider who was at risk for suicide and we needed to change their access to some supplies or medications? What would that look like? And really thinking about it in advance and problem solving it is going to be really helpful. And then you're able to say to that person, what's most important is that we keep you safe and we keep you from dying by suicide, because your life is really important to us. And so we've thought about some ways to keep people safe and be a part of their safety planning. And so that you're prepared to have that discussion, and your medical leadership, your site leadership really understands what a safety plan is, and that they understand that they may need to be involved in that process. So really giving you some things to think about a little bit ahead of time. The Zero Suicide website, I always bring it up and let people know because it has a lot of information and organizational approaches, and I think it could be really helpful. There's particularly access to lethal means training and some other trainings on there that I think you'll find really helpful. So just putting it out there, because I think preventing provider suicide and clinician suicide is really an important part of an organizational approach to suicide safer care. So when we think about some organizational responses, we talked about the hazardous vulnerability assessments. We talk also about involving your human resources or your people teams. If I'm a provider or clinician in your organization and I'm thinking about suicide, do we want to encourage them to go to the people or HR teams? Are those individuals trained? Would they actually know what to do? And oftentimes when someone makes a suicidal statement or it comes to light that someone might be at risk for suicide, managers often reach out to the HR, the people teams. Do they actually know what to do? Have you talked about, if you're the HR team, what would we do if someone called and told us that they were thinking about suicide or that they had a staff person that was thinking about suicide? What would our response be? And really thinking about that ahead of time. And also thinking about, how do we treat someone that might need some additional time or some additional support? One of the other really important pieces to think about is some of the organizational response. So if we have someone that doesn't come in for a shift or doesn't come in to the organization when they're scheduled, oftentimes, we think, well, maybe somebody just didn't show up. But do we reach out to them and let them and find out whether or not they're okay? Because oftentimes that could be somebody who might be at risk. I would also think about what happens if someone gets identified in social media. Many, many times I've had staff people, individuals come to me and say, I'm really concerned. It's actually, happened. We had a practice and it was in a smaller community, and one of the medical assistants saw actually that one of the actually a senior chief resident had made a suicidal statement on Facebook, and so wasn't sure what to do. Actually called someone in the evening when they saw it. And so really thinking about what would we do if someone makes a suicidal statement or a comment on Facebook, or we know that somebody might be at risk and we see it in social media or someone brings it to our attention, what actually would we do and what would our response be? So in that case, we actually had the medical director call them, talk to them. We had them come in. We made sure that they were safe. We did some safety planning. We connected them to care. But that was something that they worked out. And then afterwards, they said, you know what, we really need to think about this and have a little bit more of a process in place. And so they put it in as an incident. And actually, the chief resident agreed to be sort of the process going forward to put something in place for others. So really thinking about some of these things ahead of time, because the worst time to do some of this or to think it through is when you have a problem. And so thinking also about the culture comes from leadership. It comes from medical leadership. It comes from the clinical leadership. If we talk about suicide, if we give people the opportunity, if we say at a staff meeting, if we say at onboarding, I heard the numbers recently about clinicians that are affected by suicide and dying by suicide. And I want to make sure that we don't lose anyone in this organization to suicide. And I want to make sure that anyone who's thinking about suicide knows that they can come to me, that they can come to us. Here's some things we've thought about in terms of connecting people to care. And so that you're putting it out there and you have that language, because it really does come from the leadership in creating that culture. And I would encourage you, do your medical directors, do your clinical leadership have a guide, what to do, what to say, create something for them, give it out to them. This is actually going to be the way to get in front and prevent clinician suicides in your organization. And so really think about what that looks like, put it together, personalize it, have a one-pager that you're giving out to to people and leadership in the organization. So I also would strongly recommend that you give out an FAQ, and I almost would really recommend that you personalize it for clinicians across the organization, so that they have some information and resources, an FAQ for clinical, providers in the organization. And I think it's just really helpful to be able to do that. And what it does is it helps facilitate a culture where we actually talk about behavioral health needs, and particularly about suicide. And we need to be really clear that, I've heard so often from individuals who have had to do some safety planning at work. One of their biggest concerns is that now I'm not going to be eligible. People won't think I'm fit to practice by myself. People won't think I'm fit to go into a leadership position. I'm worried that I'm not going to get promoted now, or that I'm not going to be able to grow in my organization. And so it really needs to be very clear to people, and you really need to create that culture. So one of the things that you really might want to do is think about some training. What is it that puts someone at risk, right? So we know that if someone's talking about suicide, they're more likely to die by suicide. So I wish I could go to sleep and never wake up, right? Those sort of kinds of vague statements, oftentimes we don't pay attention to those statements, but really giving people language that says, you just made a statement to me that, you wanted to go to sleep and not wake up. And I know, we're all exhausted because we've just been working so much lately. But I just want to ask you and clarify, I'm wondering if you're thinking about suicide. And so you're asking people that make a statement, because people who do make suicidal statements, or people who talk about suicide, absolutely are more likely to die by suicide. So think about some training for managers, think about some train the trainers to be able to talk about suicide, to do some role plays, have it be part of your leadership or managerial training, so that you can keep it going and make sure that it really gets built in and baked into your organization. And think about all of your clinical departments, so your nursing, your lab, your primary care providers, so that it really gets baked into the training, both the training onboarding when people are coming into the organization, but also some sort of yearly training. And then how do you know training's successful? One of the big things for me is, if we're going to do a training or something, how am I going to know it's successful? So oftentimes, are we doing a role play then, right? Do we want to do, I remember working in the health centers, we had to do something where, somebody would call and make a bomb threat, or somebody would do, well, maybe we practice this as part of our disaster prep and preparedness, that we actually practice some of, having someone die by suicide, having someone make a suicidal statement, that sort of gets baked in. And I would actually put it as part of your quality efforts, as part of your training efforts, so that you can continue to really encourage that. And that maybe there's a champion, as you start to do this work and have some of your conversations around suicide, and let people know, listen, we want to prevent residents that come and train with us from dying by suicide, because we know many residents struggle with suicide, and we know many residents die by suicide. And so one of the things we want to really do is talk openly about suicide. And I'm wondering if there's someone here that's interested in maybe being a leader, right? But if you have those conversations and do the work, oftentimes champions rise. I'm really struck by the time I was actually training pediatric providers in New York, and there were also residents there, and there was a resident, and it was before we started to do some of this organizational provider work, and we were doing a suicide safer care training for patients, and he raised his hand and he said, I just want to share with everybody in this room, because you're talking about suicide. He's like, I have really thought about suicide in my past, and there are some days that I still think about suicide. And he said, there was a time in my life when I tried to take my life. And he said, so suicide is real, and it's in our patients and it's in our team. And he just said it so eloquently. And I remember people really thinking like it just made it very real for people, and sharing his story. And so I think when you start to have the conversations, champions will rise, and you will find that people will share their stories. And that's going to really help you do some of this work. So again, creating a culture of wellness, that the lifeline is there. It's posted everywhere. It pops up on the computer screens, offer some educational opportunities around suicide, right? Give people some information. Start to really think about suicide across your organization so that your postvention is prepared beforehand. Because let me tell you, one of the things I know is that if organizations don't prepare and they have someone die by suicide, it is really just upending for an organization. It's so tragic for the organization, for the staff, for the patients. And we really want to try to be preventative so that nobody dies by suicide in your organizations. And there's lots of ways to be able to get ahead, but also thinking about some of the postvention pieces. So we've done some work in the past, and there's some folks who are real champions in the field, but it's really important to start to actively address what people's concerns are. So clinicians are like, are people going to feel less about me? Address these openly and publicly. Is there confidentiality? If I have to ask for time off from rotations or from clinical care to go seek treatment, is that going to be a problem? Are people going to know, right? And what does that look like? Am I going to have time if I'm in 10 sessions a week of patient care? When am I going to be able to go and get treatment? What does that look like? And so how can we actively address those concerns? And also, there still is stigma that people feel that they're a lesser provider, a lesser clinician, if they need behavioral health treatment. And so really making sure that you're actually doing an FAQ or actively answering and talking about some of these concerns. And also the credentialing and licensing applications. We did a wonderful presentation with Dr. Barrett, who does some of this work nationally. And it's really incredible how often we actually really put up barriers for people. So it's important to talk openly about seeking care. That there's also an anonymous process for an EAP, as an example. Consider what it means for people who don't want mental health treatment, right? And also the opt-out of mental health care, so that if people are getting mental health care, then it doesn't affect them at work, right? We want to make sure that we've got some agreements with some mental health providers so that they have options, that are options, evenings and weekend care. Also waiving some copays. If we know that it creates a barrier for people, are there things that we might be able to do? What does that look like, and how can we make that happen? How would they access it? Do we do it across the board, or what does that look like? And so that's often really helpful to waive those copays, and what that would look like. So Dr. Barrett has done some wonderful things around credentialing and physician mental health. I really encourage you to look up some of her work or to go back to the webinar that we did with her. I learned some incredible things, and she really had some amazing considerations. And I thought back to all my years where I worked in the FQHC and sat on the professional appointment committee, and how often some of the questions and the processes that we had were really difficult, because people who had sought treatment or people who were in care actually really were discriminated against in the application process and had to explain. And so it was really problematic. And I love the fact that she's actually advocating for removing some of the barriers, and that it's not necessary to ask some of the questions that we ask. So that we can change things. And here's a code that you can actually scan to get some of her information and some of the presentations that are there. So I strongly encourage you, to think about what your professional appointment process is, your credentialing process, because you can say one thing organizationally, but if you still have some of those processes in place, that's what a clinician gets exposed to when they're coming into your organization, and it can just be really difficult. And so there's some questions that you could actually ask. So in other words, it's not as much about your treatment or your history, but is it a condition that really impacts your ability to practice medicine in a safe, competent, ethical way? And so really encourage you to think about the questions that you're asking, to maybe replace some of the questions in some of the processes, because that actually does send a huge message. And also, I love this idea of, a statement around getting help and putting this as part of your onboarding professional appointment process. Like, hey, it's common for clinicians to feel overwhelmed and to seek help. We want people to seek help. And when I think about it as a clinician, right, or in an organization, I want people to get the help when they need it. I don't want someone to get to the point where they're actively thinking about suicide or have tried to die by suicide, or where they're impaired so that they're not making good decisions, or they're not really present with the organizational responsibility and patients. And so to say, hey, we support you going to get for treatment, we want you to get treatment, I think is an incredibly powerful way for organizations to start their relationship with clinicians. So that we can really make sure that we're setting a good stage, and that we're actively identifying times for intervention. And this is really the key to prevention, right? Those suicidal statements, information from collaterals, people calling and saying, hey, I'm really worried about this person. Can you just watch them for me? Right? I mean, that's all so important. And also to note the signs. If somebody makes a suicidal statement, if they're going through a difficult time, I know that recently you've had a relationship and that you're having to move, and you've really been going through some financial struggles. I just want to let you know that if you're ever feeling hopeless or thinking about suicide, please talk to us. Or asking people very directly about suicide. The research is overwhelming that if someone is not thinking about suicide, asking them about suicide is not going to give them an idea, right? And so you really want to just put it out there. Like, it's okay to not be okay, and to remind people. And so really thinking about what those interventions look like. So I know we have a little bit of time left. I actually wanted to leave some time for some questions and some discussion. So I know also really helpful to put some questions or discussion in the chat. Feel free to do that as well. We will, of course, be sharing the presentation out there, as well as the recording. And I guess I just can't stress enough, it's been very disheartening to me to hear from so many health centers who are losing clinicians to suicide. And so really encouraging you to think about how you can get ahead and be on the prevention side. So I so appreciate you joining today and being part of the discussion, and hopefully it was thought-provoking and gave you some suggestions. And if you're feeling shy, feel free to put messages to me directly in the chat or out to everyone as well. So there's a question here to me around liability and changing the professional appointment process. I really encourage you to go to Dr. Barrett's information, because that's something she's been incredibly thoughtful about. And the article that was mentioned here could actually answer a lot of those questions. And so that's something she's been really thoughtful about. And I know the answer is no, it actually is fine to use some of that new language that we talked about here and that she's presented on. So thank you for that. And I would love to see you change some of the language potentially. Any questions or comments? As always, we share the information, but if you would like additional information or training for your organization, for primary care providers, for patients, or for your organization to think about an organizational approach, please reach out to the Primary Care Association, reach out to ACU, and we would be more than happy to help you on this journey to be a suicide safer care organization, to prevent deaths in your patients, to prevent deaths in your team members. So thank you. Okay, so maybe it's the holidays today. Everybody getting ready for the holidays. Do you have any other best practices for postvention? Yeah, actually, in the organizational one, we talked a little bit more about postvention. I really encourage you to sit down with your disaster prep team or your leadership team and actually say, I would put it into 3 buckets. We have a high profile death by suicide in the community. And I mean high profile, meaning that it went in the press. I had a health center recently in Michigan. They had an adolescent die by suicide in the community. And so they really had to think about an organizational response, because they had lots of school-based health centers, and now all of those adolescents were more at risk. And then I would think about, what if we have a patient die by suicide? And then what if we have a team member die by suicide? What would we need to do? Who becomes more at risk? Who would we need to notify? What would we send out to the organization? An email that we would send out to, or a communication to the organization? What would be the response for any public? What would we do for the family? Would we do something in terms of support for where this person practiced? We know that those patients automatically become more at risk. How are we going to communicate to the patients? So there's lots of information on postvention out there, but I encourage you, the other webinar, we did talk about that. And then, of course, we do have office hours, and that people can call in, share resources, ask questions. So I encourage you to join us there as well. Thanks. Great questions. So Rick, I'll turn it over to you and Cindy to close us out today.
Great. Thank you, Dr. Little. And just to remind people, we do have a couple of remaining sessions in our ongoing series. The next one, Suicide Safer Care for Behavioral Health Providers in Primary Care Settings, will be on January 11th, 2024, and you can find the link to register for that in the chat. We'll hope to see you at that, and also at our later office hours webinar. You can also find more resources, as we mentioned before, too, on our Suicide Safer Care page on our website. In the meantime, Dr. Little, Cindy, thank you so much again. This was wonderful training, and we will look forward to the next series. Thank you all so much for your time. Have a great day.
Thank you. It was a pleasure.
Thank you.